Good afternoon, everyone. So we stopped here yesterday where we spoke about initially a little bit about the anatomy and of the kidneys. And if you remember, we discussed different compartments, the glomeruli, tubules, interstitium, and the blood vessels, the four different compartments and how they clinically would be damaged and how those clinical presentations would present to us in different scenarios. And then when we finally concluded saying that there are different clinical presentations of patients if they have any abnormalities of the kidneys. And depending on that, this is how patients will present to us initially. And we need to know first to identify what this clinical presentation is, know what the underlying causes for these presentations could be, and then define the underlying pathology. So today I'll pick up from there, and I'm going to mainly talk about CKD and AKI. So those are the two topics given to you in the lecture schedule. However, I'll also touch a little bit on nephrotic, nephritic, and RPGN as well, because these 5 clinical presentations you need to know about when a patient presents with a suspected kidney involvement. So to start off with, chronic kidney disease. So this is a progressive condition over a period of time, which means that because it's progressive, you have time to adapt to these metabolic derangements secondary to impaired renal function. So how do we define CKD? CKD is defined as abnormalities of kidney structure or function, which should be present for more than 3 months with implications to health. So what are these abnormalities of the kidney? It could be a structural problem or it could be a functional problem. So these are some of the ways that kidney abnormalities can be present. You can have abnormal proteinuria of albuminuria of more than 30 milligrams per day. If you can have abnormal urinary problems like hematuria, red cell CAS. You can have electrolyte abnormalities which you suspect are secondary to tubular dysfunction. You can have abnormalities detected at your kidney biopsy in histology. Or you can have structural abnormalities detected by imaging. For example, single kidneys, horseshoe kidneys, polycystic kidneys, those are structural abnormalities. Or you may have a history of kidney transplantation. Functionally, if you look at kidney function, if you have a GFR of less than 60 ml per minute per 1.73 square meters, all these conditions are considered abnormalities either in the structure or the function of the kidney. So if a person has at least one of these, which are persistent for more than 3 months, then you can consider this patient to have underlying chronic kidney disease. However, one thing you need to know is that in normal people also, with age, your kidney function can decline. And these are 2 graphs showing what happens. So in normal men also, up to about age 40, you maintain normal GFR. But after about age of 40, you can see that there is a gradual drop in GFR, both in males as well as females. So this is a natural phenomena. Here, just because your kidney functions are declining, you don't consider it as CKD. There, it happens because of aging. So how do we evaluate GFR? So yesterday we discussed this. You use serum creatinine, and with the use of creatinine, you put this into estimating equations to calculate the kidney function with respect to glomerular filtration rate. So these are 2 common equations, and out of this, the CKD EPI is the currently considered standard equation to calculate estimated glomerular filtration rate. And you can remember from yesterday's discussion, we said that because it's very cumbersome to calculate the true glomerular filtration rate, where you need to have very meticulous investigations, you have to collect these samples for 24 hours. And because this is not practically possible, we tend to calculate it using these equations as an estimated glomerular filtration rate. So once you do this test for these patients, you calculate the GFR, and now you've diagnosed CKD in a person where their kidney function is low and that has been going on for more than 3 months, you consider them as CKD. The next thing to do is to stage the CKD depending on the severity. So one of the criteria or the main criteria that we use to stage CKD is according to your glomerular filtration rate. So if you have a GFR or glomerular filtration rate of more than 90, you consider it as stage 1 CKD. If you have it between 60 to 80, you say it's stage 2 CKD. 30 to 59, stage 3 CKD. 15 to 29, stage 4 CKD. And less than 15, stage 5 CKD. And as you would realize, lower the GFR, higher the CKD stage, higher the severity of chronic kidney disease. So that would be your next step. So first, to diagnose CKD. Number 2 is to stage the CKD. The next step in the management of these patients is you need to identify, okay, now we've diagnosed CKD. So what is the underlying cause of this chronic kidney disease in this patient? There you can classify it according to which compartment of the kidney is affected. Like we discussed yesterday, it could be pre-renal, all this is considered intrarenal, or it could be post-renal. Pre-renal means the pathology is initiated prior to coming to the kidney. So especially if you have vascular problems, blood flow problems, perfusion problems to the kidney, those are considered pre-renal causes. If it is the abnormality is occurring within the kidney, and where it could be the glomerular abnormality, tubular problems, interstitial problems, vascular problems, you call it intrarenal causes. And if this is occurring after the kidney, that is, it could be in the renal pelvis, ureters, bladder, if there is a cause there, those can be considered as post-renal causes of chronic kidney disease. I'm not going to go through this list. You can go through it leisurely. These are some of the causes where each of these compartments are affected and which leads to chronic kidney disease. So basically, whatever the system that's affected, and you can remember yesterday I mentioned that each of these compartments are interconnected. The glomerulus, the tubules, interstitium, vascular, all are connected, interconnected. Whatever the compartment that is affected, at the end of the day after a file, the whole kidney starts getting affected with this. So whether you have a glomerular condition, interstitial disease, vascular disease, it goes through many pathophysiological processes and finally leads to tubulointerstitial fibrosis with glomerular sclerosis. And that is when you consider this patient to have chronic kidney disease, and therefore your GFR starts going down, a patient's urine output starts going down, and then the patient starts developing complications secondary to the underlying chronic kidney disease. So this is a classic example of a patient presenting with a suspected chronic kidney disease, and I'm sure with all the medicine appointments you have done, you have met at least 1 or 2 patients like this with a classic CKD history. So this is a 59-year-old male patient who's presenting with non-specific aches and pains. He has a past medical history of type 2 diabetes mellitus for more than 20 years. On examination, he's pale, he's having lower limb edema, and he's hypertensive with a blood pressure of 170/80. When you do the investigations, you see a creatinine of 580. He's anemic with an HB of 7.8. Bicarbonate is low at 16. Serum potassium is high and he's hyperkalemic at 6. Serum calcium is low. Serum phosphate is high. And you do the parathyroid hormone levels, that's 15 times higher than the normal range for this patient. And in the urine fluid report, you see proteinuria of 2+ with occasional red cells. So this is the typical picture you will see in a patient suspected with CKD. So we'll go through one by one of these symptoms and these complications. So these are the common clinical features of a patient suspected to have CKD. And as you can see in the picture, it is more or less affecting all body systems. Therefore, chronic kidney disease is considered a multi-system disorder where almost all of your body systems can get affected. So you can have hematological involvement, skin involvement, GI involvement, endocrine involvement, neuro involvement, bones in getting involved, cardiovascular system getting involved, nervous system getting involved. So by the time you come to final year, using your knowledge on physiology and biochemistry regarding renal physiology, you should be able to explain all these abnormalities. This you have done during your physiology days, and I'm not going to go through each one, but I'll highlight a few of these symptoms and complications. So what happens when your kidney functions goes down in CKD? One of the main things is your sodium balance becomes affected. So you know kidney normally manages your sodium and water balance in the body. When you have low kidney function, the patient starts retaining sodium and the patient starts getting volume overloaded. At the same time, your potassium excretion is impaired. Patient starts getting hyperkalemic. When the tubules and the acid-base homeostasis mechanisms get affected with CKD, that is when these patients start developing metabolic acidosis. As you know, your calcium phosphate balance is mainly regulated with your kidneys, where you know that your vitamin D active form is formed in the kidneys, and that along with vitamin calcium phosphate and PTH governs your mineral bone systems. So in CKD patients, we will discuss later, there will be abnormalities of these. Your erythropoietin is secreted from the kidneys. So in CKD patients, erythropoietin deficiencies occur, and this can affect erythropoiesis and lead to anemia as well. So these are some of the main complications you are going to see in CKD patients. If you talk about edema, again, as I mentioned, your GFR goes down. These patients retain lots of sodium and water, which leads to increased hydrostatic pressures intravascularly. And if you can remember the Starling forces in your physiology days, the higher the hydrostatic pressure, the more tendency for fluid to be pushed out into the interstitial compartment, and these patients end up with generalized edema, lower limb edema, pulmonary edema. There could be other mechanisms where these patients can be malnourished. This can lead to hypoalbuminemia, and also these patients can be uremic because your uremic toxins are going to get accumulated, and that can result in pleural effusions, pericardial effusions. So all these can contribute to edema and fluid accumulation in patients with CKD. How does anemia occur? I mean, at first instance, we always feel, okay, CKD, they are erythropoietin deficient, and that is why you get anemia. But in CKD patients, that is not the only reason they get anemia. There are multiple mechanisms and reasons why a patient with CKD will get anemia. So as you know, these patients are having high creatine, high urea, and they are going to have a lot of loss of appetite because of that. And that will lead to a lot of deficiencies. You can get iron deficiency, B12 deficiency, folate deficiencies. So that will lead to anemia. At the same time, the more obvious reason is that you have erythropoietin production deficiency because of the kidney dysfunction. That will lead to anemia as well. Apart from that, your red cell lifespan becomes short. When you have uremia, that will suppress the bone marrow producing red cells, and that will lead to anemia. When you have mineral bone disease, your high parathyroid levels can cause bone marrow fibrosis. So there are so many other reasons why a patient can get anemia in CKD. So you need to investigate this patient's anemia further to identify the exact reason. Another clinical manifestation is weight loss, and that is mainly because these patients, because of uremia, toxic materials accumulating in their bodies because of low GFR, will have poor intake, loss of appetite, metabolic acidosis, and this will lead to protein energy malnutrition, and they lose a lot of weight because of this. Hyperkalemia. As you know, kidneys regulate your sodium, potassium, acid-base balance. So when you have CKD, this potassium balancing cannot happen optimally. So these patients will end up with hyperkalemia, and this will lead them to develop arrhythmias, which could be life-threatening at times. Mineral bone disease. How does mineral bone disease occur in CKD? Just to put it very simply, what happens is when you have CKD, the first thing to that get affected is your phosphate excretion. The kidneys are not able to excrete phosphate adequately. And when you have high phosphate, if you can remember your physiology, endocrine lecture series, high phosphate will stimulate your parathyroid glands, whereby PTH levels go up and the body will try to secrete more and more phosphate to go out of the body. At the same time, when the kidneys are damaged, your active vitamin D does not occur and you end up with vitamin D deficiency, and that will lead to stimulation of PTH cells directly. And at the same time, when you have vitamin D deficiency, calcium absorption goes down from the gut and you end up with hypocalcemia. That will also result in high PTH levels. And when this happens, your high PTH levels go and affect the bone, where there will be a lot of reabsorption to produce more and more calcium into the system. So your bones are going to get affected. So you end up with this entity called mineral bone disease of chronic kidney disease. We will discuss this a lot deeper when you come into your 4th year. But for the moment, if you know this and understand this, that is more than adequate. So these patients with CKD will have high phosphates, they will have low calcium, they will have low vitamin D, and they will have high PTH. So if you see these 4 abnormalities in a patient, you know that you are probably dealing with a patient with CKD. So going back to our patient again, now you might be able to understand some of these abnormalities. This patient is having long-standing diabetes for 20 years. He's pale because he's anemic now for the reasons we discussed. He's having edema because of fluid retention. He's having hypertension because of fluid retention. You can see the creatinine is very high. He's anemic for the reasons we discussed. Bicarbonate is low so that he's metabolically having acidosis. He's having hyperkalemia. And these are the mineral bone disease abnormalities of low calcium, high phosphate, high PTH, and he has some proteinuria. So these are typical abnormalities you need to identify in a patient presenting to you in the ward. Right. So moving on to acute kidney injury. So compared to chronic kidney disease, acute kidney injury is more acute, as the name would suggest. So this is the current definition of acute kidney injury, which you need to really know by heart. You can use creatinine as a criteria, or you can use urine output as a criteria. So if you are using creatinine, if you have a rise in serum creatinine of more than 0.3 milligrams per deciliter, or if you are using the units of micromoles per liter, it should be more than 26.5 micromoles per liter within 48 hours. Or it could be an increase of serum creatinine to more than 1.5 times from the baseline, which is known or presumed to have occurred over a period of 7 days. Or if you are going by urine output, if you are having a urine output of less than 0.5 ml per kg per hour for more than 6 hours, those patients are considered as having an episode of acute kidney injury. So for example, if a person is 60 kilos, and if the patient's urine output is less than 30 ml per hour for more than 6 hours, that patient should be considered as having acute kidney injury. So like in chronic kidney disease, the first thing to identify in a patient is to diagnose AKI using these criteria. Once you diagnose, the next step is to identify what is actually causing acute kidney injury in this patient. And again, you divide the causes of acute kidney injury into pre-renal, renal, or post-renal causes according to the compartment it is affecting in the kidney. If these are abnormalities prior to coming to the kidney, for example, perfusion problems, and the list of causes are here, then you consider it as a pre-renal cause of AKI. If it's affecting the glomerulus, it could be one of these. And you know how glomerular damage can manifest clinically. It could be proteinuria, it could be hematuria, like we discussed yesterday. If it's the tubular or the interstitium that is affected, these are some of the causes you need to consider. And if it's the blood vessels, these are some of the conditions you need to consider. Or it could be post-renal, after the kidney, where it could be obstruction at the bladder level, the ureters or the urethra, where that can result in acute kidney injury. So when you have a patient suspected of AKI, then you need to identify the cause, and these are some of the and identify how these patients present clinically. So again, this is a typical history of a patient suspected to have an acute kidney injury, and I'm sure you have met enough patients like this, especially in your surgical appointments. For example, this is a 36-year-old male patient presenting with a 3-day history of taking ibuprofen after a toothache. The patient, after taking ibuprofen for 3 days, starts noticing loin pain and mild ankle edema. And when he does the investigations, the patient is seeing high creatinine with a urine protein and eosinophils. So before even going to more investigations, you can clinically diagnose that this patient is having acute kidney injury because this creatinine is high. It's happened within a few days, and you have already a drug that is contributing to suspected AKI, your ibuprofen. And here we can clinically say that this is probably acute kidney injury secondary to non-steroidal anti-inflammatory drug, which is the ibuprofen. So I'd like to put one or two slides on this entity, what is called rapidly progressive glomerulonephritis. This is again another type of acute kidney injury. The only difference is that apart from features of acute kidney injury, you have features of a nephritic syndrome. So nephritic syndrome is that you have high blood pressure, you have an active urinary sediment, or that means hematuria, red cell cast in your urine, indicating the problem is happening at a glomerular level. So when you see a patient with AKI with evidence of glomerular hematuria, then you call this to be rapidly progressive glomerulonephritis clinically. Here you have rapid decline in renal function within hours to days. And if you do a biopsy in these patients, the hallmark lesion that you are going to see is crescents. And if you see crescent-rig glomerulonephritis on the kidney biopsy in these patients, then the underlying cause should be one of the following mentioned causes. It could be antiglomerular basement membrane disease. It could be immune complex mediated diseases such as SLE, post-streptococcal glomerulonephritis, or IgA nephropathy, or it could be a post-immune GN such as ANCA vasculitis. Now, I'm sure you have been taught crescent-rig glomerulonephritis during your renal pathology lectures. So I'm not going to go into details, but I'll just show you what crescents are going to look like. So here, this is a normal glomerulus. And one of those causes that I mentioned are going to cause damage at the glomerulus, your endothelium, and there's going to be a lot of inflammatory cells that are going to come in here. And that's going to start stimulating your parietal epithelial cells here. This is your parietal, and that's going to stimulate that. And those cells are going to start proliferating, as you can see. And those cells are going to fill up this urinary space. And you are going to end up with this structure called crescents. And if you do a biopsy, this is what you are going to see. You are going to see these crescents. And the diagnosis is going to be a crescent-rig glomerulonephritis. So how do these patients with AKI and RPGN present? They will come with a rapid loss of renal function. So your creatinines are going to shoot up very rapidly. Patients could be oliguric or anuric. And if it's an RPGN, these patients will have features of a glomerulonephritis, where there will be dysmorphic red cells, hematuria, red cell cast, and glomerular proteinuria. So clinically, that is how you are going to identify a patient with acute kidney injury. So those are the two main topics I want to discuss, AKI and CKD, but I will touch a little bit on the next two topics, nephritic and nephrotic syndrome, because those are also clinical presentations when your glomerulus is affected. So I'll start off with nephritic syndrome. Nephritic syndrome is when you have these clinical features. If a person presents with hematuria, oliguria, hypertension with a little bit of edema, that is when you call a person to have nephritic syndrome. And as you can imagine, you can diagnose this clinically, a patient with hematuria, oliguria, hypertension, and a bit of edema. And this typically happens because of a glomerular nephritis. So these are the common causes that will cause a nephritic syndrome picture. Your post-streptococcal glomerular nephritis, infections, IgA nephropathy, inoxagon-like purpura. And so these are some of the causes that's going to cause acute glomerular nephritic syndrome. So I'll take one example. So this is a typical picture of a post-infectious glomerular nephritis. There you have the normal glomerulus, and you can see a biopsy sample, and you can see the normal glomerulus, patent glomerulus. So this is a normal glomeruli. And here you can see a patient who's having post-infectious glomerular nephritis. You can see there are neutrophils, and the lumen of the glomerular capillaries are obstructed. So this is the biopsy of a similar patient. You can see here, you can nicely see these glomerular capillaries, but here you can see all neutrophils that's going to obstruct the capillary lumens. So this is a typical picture of a post-infectious glomerular nephritis. So what's the pathology behind it? As you can see, there will be lots of inflammatory cells that are going to come into these glomerular capillaries, and it's going to obstruct these capillaries, and it's going to damage the capillary endothelium. So when it injures the capillary endothelium, you will start getting the red cells going out of the glomerulus, and you end up with hematuria. And on the other hand, when the glomerular capillaries are obstructed with all these cells and the damaged cells, it's going to reduce the GFR. Patients are going to develop oliguria. The GFR is going to go down. These patients are going to retain a lot of sodium and water, and that's going to lead to a person developing edema and hypertension. So that is how we can explain hypertension, edema, and hematuria and low GFR in these patients who present with a nephritic picture. The next clinical picture is nephrotic syndrome. Now, these are features that you need to know by heart and understand well. So nephrotic syndrome is characterized by heavy proteinuria of more than 3.5 grams per day. So if you can remember our discussion yesterday, we mentioned that a normal person can pass up to 150 milligrams of protein per day. So to call it nephrotic syndrome, you can see 3.5 grams means 3,500 milligrams of protein per day you need to have to call it nephrotic syndrome. And along with that, a person should have low albumin, generalized edema, and these are the three main criteria to call it nephrotic syndrome. Apart from that, a person can have hyperlipidemia and lipiduria as well. So I'll go one by one to explain how these occur. So this is a typical case history of a patient who is presenting with a picture of a nephrotic syndrome. So it's a 58-year-old male patient will come to you saying, I have generalized edema and frothy urine. So the moment a person says edema and frothy urine, you know that this patient is having significant proteinuria, which has led to edema and a nephrotic syndrome. And when you do the investigations, you can see there is protein of 4+, no red cells. They calculated the amount of protein per day that they are passing, and they have the patients currently passing 7 grams. That means 7,000 milligrams of protein per day. And the serum albumin is very low. It's 1.8 grams per day per deciliter, and you know the normal range is up to about 3.5 and above. And the total cholesterol is high. So when you see this clinical picture, you have to clinically diagnose nephrotic syndrome. So that would be the first step. So the clinical diagnosis would be nephrotic syndrome. Once you diagnose nephrotic syndrome, you need to try and identify what is the cause of nephrotic syndrome in this patient. And there are many causes, and we will discuss each of these conditions later, but I'm sure you have already been taught some of these conditions in your renal path lectures. So you divide it into primary and secondary. Primary means it's purely a disease of the kidneys, and where you can have minimal change, focus segmental glomerulosclerosis, membranous nephropathy, causing nephrotic syndrome. There are some secondary causes such as diabetes, SLE, all these conditions which will also lead to nephrotic syndrome. So these are some of the pictures of renal biopsies, and you have already been taught this for a renal path. So this is a patient with minimal change disease, where this picture is a normal glomerulus, where there is the endothelium and the podocytes nicely there. And here this is the appearance when this person has minimal change disease. And you can see these podocytes are now flattened. You call that effaced podocytes. And if you can remember from yesterday, we mentioned that if the abnormalities happen on the outer side of the glomerular basement membrane, these patients are going to end up with significant proteinuria. So here, this patient has proteinuria. If you look at a light microscope will look normal, and that's why they call this minimal change. But if you look at it under an electron microscopy, you will see these abnormalities of podocyte effacement. Similarly, this is another condition called membranous nephropathy, where if you remember yesterday, we spoke about immune complexes getting deposited in the kidney. So this is a condition where immune complexes are formed within the glomerulus, and you can see here it is formed and deposited on the outer aspect of the glomerular basement membrane. Therefore, you call them subepithelial deposits. So that is going to damage this compartment, and these patients are going to end up with significant proteinuria. And when you do a renal biopsy, this is what you are going to see. You will see these glomerular basement membranes getting thickened. You can imagine all these immune complexes forming and depositing there. That is going to make this glomerular basement membrane look thick. And that is what you are seeing here as thickened basement membranes. So what are the complications or the manifestations of nephrotic syndrome? So these are the common ones which you need to know how to explain. They can have hypoalbuminemia, edema. They are at high risk of infections. You can have hyperlipidemia, hypercoagulability, and hypovolemia. And I'll go one by one explaining how these occur. So if you talk about hypoalbuminemia, how does this occur in nephrotic syndrome? There are two main hypotheses. One is called vascular underfill hypothesis, and the other one is called vascular overfill hypothesis. In underfill hypothesis, how we explain this is, if you have heavy proteinuria, with that you lose a lot of albumin, so your serum albumin levels go down. And when you have hypoalbuminemia, your plasma oncotic pressure goes down. And if you can remember your Starling's forces, when your oncotic pressure is low, the fluid is going to get pushed out of the vascular compartment into the interstitial space, and therefore you start developing edema. Along with that, when the fluid is pushed out, your circulating volume is less, and that's also going to activate your renin-angiotensin system, and that will preserve more sodium and water in the body. And with that retention, that's also going to make the edema worse. So that is called the underfill hypothesis, because with this albumin low, your intravascular volume is going to be less. Therefore, you call it underfill hypothesis. The other hypothesis, or the way edema can occur, is when you have heavy proteinuria, that protein goes through the tubules and is going to stimulate these channels in your distal tubules called the epithelial sodium channels to activate. And when these get activated, it's going to retain more and more salt and water, and that's going to make the edema worse. So that is your overfill hypothesis, which is going to contribute to developing edema. The other complication is infection, and as you would realize, with heavy proteinuria, you are going to lose a lot of cytokines, immunoglobulins. So with that, these patients are more prone to get infections. How do these patients get hyperlipidemia? So clinically, these patients will start developing high LDL levels, high total cholesterol, triglycerides. The exact pathogenesis of this is unclear. However, what is postulated is that when your albumin levels are low, there is a stimulation to the liver to produce more and more albumin. Along with that, in an unregulated manner, your lipid productions are also going to go up, and these patients end up with hyperlipidemia. Hypovolemia is another complication. As I mentioned before, what happens here is that when you have low albumin, your fluid from the intravascular compartment is going to go out. So intravascularly, you are going to be hypovolemic, and these patients can become hypotensive, hypovolemic, and this can become a problem. So even though from the outside the patient looks edematous, intravascularly these patients are hypovolemic. Right. So with that, I've during the talk today and yesterday, I've tried to revise the little bit about the kidney anatomy and the microstructure of the kidney. I've highlighted the importance of looking at different compartments within the kidney, the blood vessels, the glomerulus, tubules, and the interstitium separately. We've discussed about different mechanisms of injury to each compartment, where we said that it could be antibody mediated, it could be antigen immune complex mediated, or it could be non-immune mediated. And then I tried to discuss how these compartments can get affected and how these would clinically manifest. For example, if it's a glomerular damage, these patients can get proteinuria, hematuria, something like that. Then we discussed a little bit about the more important investigations about how to estimate GFR, what the importance of creatinine, about the UFR, looking at proteinuria and hematuria, and how to interpret these abnormalities. And today we looked at the different clinical presentations of each manifestation, where patients will come to you first with a clinical presentation. They will not come and tell you that I have a glomerular problem, I have an interstitial problem. They will come with a clinical presentation. So the first thing for us to do is to identify what this clinical presentation is, whether it's CKD, acute kidney injury, nephrotic syndrome, or nephritic syndrome. And depending on what presentation it is, we need to do the relevant investigations and try and identify the cause, its associated complications in order to manage this patient. So with that, I'm going to conclude. I hope you got a basic idea about how the knowledge that you are gaining during your clinical path appointment is going to be helpful for you when you come to manage patients in the medical ward setting. Thank you.